So today I'm going to be talking about a different type of disaster or epidemic, public health disaster in particular. So as a disclaimer, I'm sharing my experience and serving on numerous committees, advisory committees during the pandemic. I was also a vice chancellor of a university, so I saw how young adults responded to the pandemic at this particular period. So none of this represent my institution or the views of the committees I represent, because I stand here to share my experience and my views. So without disclaimer, I thought I should also provide, just in case I don't have the full time to go through all my slides, a summary of what I intend to do is to present public health emergencies in the context of broader disasters and global health security preparedness, particularly in South Africa, and particularly the importance of social justice or fair adaptation in driving public trust, and ends effective community response and preparedness. I'm hoping that the data I'm going to provide will be able to demonstrate that relationship, and that's what we call public health resilience. And importantly, I like the fact that the background, I don't have to go into the health systems and all the problems and the role of community, but importantly is that when we talk about community resilience, it's not only about community agency or lack thereof, but the importance of politics and the role of state and institutions in supporting or producing, enabling policy that allows community to do what they need to do and produce that environment that it makes it easier for community to take control of what determines their health, the health promotion. I would also then provide data relating to trust in response to perennial epidemic like HIV/AIDS. We always forget that we still have that as a country, and the unenviable statistics of being the capital, the world capital of population of HIV/AIDS people. So I need always to draw lessons from that because we behaved in COVID like we never had something so big in South Africa. But we are supposed to have taught a lot of people now to respond. And then I'll then highlight how mobility data in particular suggests the decrease in response to regulations of government, particularly at the height of wave 3, may have to do with the public trust that was created at that time, because whether coincidentally or not, there was also a large-scale corruption that was exposed at the same time around COVID, wave 3. And of course, we know what happened during wave 3. Yes, there was a strain that was dangerous, but there was another strain that was even more dangerous. And that's what I want to demonstrate. So, quickly, I'm going to move into the first slide. This basically provides the context of disasters in Africa. This comes from the emergency database from the Center for International Epidemiology of Disasters. And you can see, I've just only highlighted the 4 big disasters. It's epidemics, floods. Interestingly, there seems to be a kind of a pattern that goes with epidemics and flood. When it goes up, flood goes up. When it goes down, it comes down. Clearly, of course, we have a lot of people don't always remember. A lot of parts of Africa have cholera outbreaks quite often, gastroenteritis and all other epidemics that we have there. And of course, landslides, I can see ticking up. All of this, you can see, over those many years, it's only become more evident more recently. Yes, there might be gaps in data collection getting better, but clearly there's an effect of climate change that we can see as well. So we say public health emergencies of international concerns during a 10-year period would include your Ebola, your Zika, of course, COVID-19, to name a few, but COVID-19 obviously had the greatest number of deaths, and probably got a lot of more attention globally than every other one because it probably didn't affect the rich countries as COVID-19 did. And as I said earlier on, the perennial epidemics of HIV/AIDS had the largest investments in lessons to be learned. And that's why the data I'm going to use also, I decided to go back to some existing data on HIV/AIDS and see whether I could also bring out the connection between trust and how people respond. And of course, I don't think I need to tell any South African, the then president's position had a big influence on how the public responded. Unfortunately, I need to also say not how public responded, the type and the deaths that followed due to those responses. So NPI, or non-pharmacological interventions, are behaviors that people are supposed to do in order to contain the virus. But I always argue that how people behave is not determined by just their motivation, but their social influences. And that includes the way either social structures or social capital they're able to draw on in order to perform that behavior. So reducing mobility was another piece of measure, which by itself is not just an health promotion intervention, but it was also a socioeconomic emergency. It created another type of justice. And we always talk about fair adaptation in response to disasters, to the extent that some of the data you saw earlier on multimorbidity, and obviously poverty affects certain population more than others. So when you restrict movement, it definitely affects some certain people more than others in terms of having to fend for their family and look for food. And that might also influence the extent to which the community then trusts government. If you have not been looking after me and my well-being and how I'm going to feed, now how am I supposed to trust you that if you tell me to sit and not look for food, you would actually look after me? So in terms of the literature, there's been a lot of publications around trust and how that drives, particularly behavior, COVID behavior, even outside of South Africa. Mostly, these were studies done outside in Africa. Most of the studies were done in Europe, Italy, and many of those parts that had very large deaths from COVID. And compliance of population is undermined by how it affects their livelihood. I mean, I think that's just logic. But for some reason, we only got to it much later in South Africa. We just thought people would just listen and do as government asked them to do. Participation of trusted leaders was also important when we looked at the Ebola response in West Africa. Eventually, the Ebola got under control when local leaders got involved. So it's quite instructive to then check to what extent all of this in South Africa worked. I was also particularly interested from my experience in Malawi responding to flood resilience. We built a model on resilience. And the resilience outcome in that particular instance was food security. Just to cut it short, it was important whenever you had a perturbation, a disturbance in the environment of any sort, like flood, the immediate response is the social capital people are able to get directly and come together collectively, and then that allows them to have collective support and access safety net. What we then found was that enough did not sustain food on the table if they did not have any particular skill that they could go back to in order to create wealth and then continue feeding. So resilience pathway is not short coping. So you can have a coping to allow you to absorb the shock, but you would not if you do not have a longer pathway of adaptation to sustain such effect. So that's why I was interested in particularly the role of social capital in pandemics. Whether this is the same response that will be so important like the way it is for flood. And trust is a construct of social capital. So without taking you through the details of the data, we basically looked at what were people looking for on Google search during the pandemic. And we compared that to what were scientists publishing during the pandemic, looking at Google Scholar. Because that's one of the areas where we see whether science is responding to people's needs. And that time, and sometimes that creates the trust, even in science, for population at a particular time when they were in crisis. And then also looked at the role of public perception or trust of government in response and how that influences the behavioral response to either HIV self-test or know your status, and of course the compliance to MPI in the case of COVID, particularly in Gauteng province, where it was one of the most affected provinces in South Africa. By the way, COVID had more impact in Gauteng, KwaZulu-Natal, Western Cape, and to some extent Eastern Cape as well. And we then looked at trend in mobility during COVID pandemic, particularly around the Delta variant portion and the context of media coverage of PPE corruption. And then all of this within the indicators of global health security for South Africa in terms of preparedness. So these were publicly available data. The South African pandemic preparedness scale was published 2019, so that was before COVID. South Africa is supposed to have been quite prepared, as you see from the data, but we didn't quite have the outcome as expected from that index. South Africa was number 1 in Africa, but was number 54 out of 195. And like I said, we looked at Google search. We looked at the large HIV population survey, about 26,000 South Africans 15 years and older, and particularly look at the association between their perception of governments responding to the HIV adequately and them having to self-test. And then we also had a survey of patrons of restaurants and public places in Gauteng around May 2021, around the wave 3, over 2,000 looking at their behaviors as well and their perception of trust of government and their mobility data. As I said, the patron data was looking at trust and wearing masks and social distance and whether they would sacrifice their own human right, in order to stay at home and not go out, even they wanted to. So, yeah, that's just a sampling frame. I'm just going to go for time because of time. So, as I said, South Africa was ranked 34th out of 195 with an index of 54, but that did not correspond in Africa. South Africa had the largest death and impact. Yes, the health system was the most advanced and probably captured more COVID tests and COVID death than many other African countries. But even after adjusting for that, definitely there were more deaths in South Africa than others. And other studies have shown that there was no association between the Global Health Security Index and the outcomes of vaccination, for example, Israel, UK, in fact, it was almost opposite. UK, US, and Australia were in the top ranked Global Health Security Index for preparedness. But we all know UK, US did not quite get it right. Maybe Australia. And again, it's also obvious the difference between the two is the trust in government in the UK at the time and the US. Again, portraying the importance of trust in how you respond and in preparedness. So in terms of Google search, South Africa, Ghana, Kenya, and Uganda were mostly query values on the Google search engine. And some of the things that you find in South Africa was UIF. UIF is an employment insurance fund. People were most concerned on the fact that they were losing a job, they weren't getting a job. Would they be able to get fund? And of course, at that stage, there were also some connection to UIF paying out some money to those who needed the help. Needless to say, again, there was a lot of corruption that happened there. So you can see consistently, people wanted to talk, they were looking at how the COVID-19 spread, they were searching for food security issues, they were searching for symptoms, there were particularly a lot of Google search on Russia and the vaccines, for whatever reason. And then of the 530 publications on COVID and Africa, most of those authors were not from Africa, and very few made explicit reference of lessons from Ebola, and most of the titles were on the COVID virus itself, pandemic and disease. So you can see from the word clouds, there was no direct connection between what the population wanted to know about, issues around loan, how to get money, and then what the scientists were researching. This was in terms of the HIV survey. It was clear, you can see the connection between HIV population and HIV negative population when we looked at the role of trust. For the HIV population, the outcome was likelihood of being aware of their HIV status because there was a campaign, Know Your Status. For the HIV negative population, the outcome was receiving past year HIV tests because you also were encouraging people to test themselves. And you can see consistently the issue around things like political leaders are committed to controlling HIV/AIDS. The more people agree with that, the more likely they know their HIV status for those who were positive, and the more likely those who were negative have taken an HIV test. And you can see it for all indicators related to government response. It was consistently, significantly associated with all those indicators. So we then moved on to, I would now focus more detail on the surveys in Gauteng province that was mostly affected by COVID. Again, this was a survey that involved all population groups in South Africa, about 104 wards in Gauteng, and about 2,000 respondents. So this table, what is important to take away from here is staying in, where is it now? Oh, this is, all right. I think it's that, it's the third one. Staying in my house, look, less social interaction except absolutely necessary. Less than half of the population would do that. So movement was a problem. People would not respond to the restriction in movement. Again, understandably, they needed to go look for food because the UIF was not working very well. It was 350 Rand, and that was probably not enough. And you can see that from the Google mobility data that I'm going to show later. You can also see that trust also in us when you ask the question, when I screen, I always leave my contact details. That was an important contact tracing intervention, but people never trusted to leave their contact details. I'm sure those who know South Africa and crime, you will know why it is difficult to do that. And you know why it would be difficult to control pandemic just from the public health perspective without looking at these socioeconomic issues. You can also see in terms of knowledge, it was quite instructive. If you look at the last column on the confident, that is definitely do you feel the source where you receive the most information about coronavirus can be trusted? Only 7% said they definitely do. Just 7%. 57% were not sure. So we had a population that were just responding in blindness. It was so easy for Twitter to capture everyone. So everybody knew about COVID. Everybody became an expert except the scientists. And the scientists were just looking for strains. An unfortunate situation in a crisis. Again, similarly, when we asked the respondent, do you think the national government is handling coronavirus well in terms of trust to national government? That was quite high, almost 69%. But remember, the national government made policy they did not have to implement. So it seemed like the policy, everything sounded good. We're going to provide economic relief, we're going to do this, we're going to do that. But when it came to the province, only 39% or 38.6% believed the province was handling the COVID well, where the implementation was supposed to happen. And again, you will see what the media then said, what was happening in Gauteng at that particular point in time. So again, this is quite a busy slide. I think I'm just going to draw your attention to the population group, historically self-identified, people who self-identified as Black Africans. A majority believed the threat from COVID was exaggerated. That's what we call defensive response. When you have no other way out in behavior, you sometimes take a defensive response, and therefore they have to still go out to fend for food. Also, from this table, important to take out is that those with less than matric or low socioeconomic status, the majority, a lot of them also believe that the threat from COVID was exaggerated. You can see the commonality. And interestingly, in Tshwane, which is the capital of the country, a lot of people also felt it was exaggerated. Again, people needed to survive. Young people were the most hesitant for vaccine. I mean, I saw all of them on campus, and they just didn't believe it was all necessary. Again, they were on Twitter. They didn't get any other information, but mostly on Twitter. And it goes on for this as well. Young people were least compliant to wearing face masks always. Those who were of low socioeconomic class status were also least compliant, and also in the city of Tshwane. So we classified the population into two extreme responses. One is the defensive response, that is, they say they could be at risk, but the whole thing is over-exaggerated. That's a defensive response, that about 35% of the population had this defensive response. They were more likely to be African Black, lower education, lower knowledge, and greater social impact. They were more likely to say that it's affected my employment, my income, my ability to get food. So we need to be aware when we respond to future pandemic, there's the population group that sometimes needs to take their attention of the state. Again, when we control for the different variables, it also became consistent that trust in government was associated with wearing masks, a high odds of wearing masks, and a high odds of taking on vaccine. But interestingly, the defensive response was associated with lower odds of wearing masks, but a high odds of actually taking the vaccine. So it seems to me that they could not probably afford to wearing of the mask, but the vaccine, but yet they knew they were at risk. They played it down, but when the vaccine came, they were the first to actually also take on the vaccine. And before I showed the movement, these were the headlines in South Africa. In the circle there is Gauteng province. This was the Special Investigation Unit in South Africa reporting on the number of cases. So the number of cases you can see in Gauteng was highest. The next is just an addition of all the total for the country. And then you see the headlines like, you know, that was the head of the province, the premier at that time, about PPE corruption, why he didn't do anything. We're talking about the region of billions of rands. And then here's the movement data. At the same time, if you see the movement, wave one, people went home, and there were reduced movement in malls or social areas, but residential was higher. Wave two, not as high and not as low. And wave three, that's when deaths happened. People did not stay home. They were just all moving in the malls. That's the gray area. They lost trust completely. With all of that corruption, they wouldn't take it. So no matter how much variant we knew, scientists were busy identifying species and variants. Corruption was happening. People were not getting income. People were moving out to survive, even though at the risk of death. And that's not how to respond to pandemics. So as I conclude, the OECD has provided a framework on how to build trust. We need to build trust again in order to better prepare for the next pandemic, because we all know this is not the end of public health, or end of pandemic, but the disaster could get worse if we are not better prepared, if we don't learn from what we've gone through. So in summary, the OECD says, and I say the COPC is a very good model where you have community healthcare workers on the ground, they know the community, they're trusted, and they can connect with government institutions through PHC, the primary care clinics, that we can start using that instrument to build trust again. One, provide responsive quality public service, because we shut down everything else because there was COVID. Again, they just got fed up. I mean, these were people looking for their medicine, they struggled all there already, and now we have to catch up. And of course, that's also making, the reality today is that we need to do this catch up, and we have to do it in a way that we build trust in communities. We need to minimize uncertainty in economic, social, and political environment. What is happening in the last 1 week is not helping any. Can you imagine any pandemic breaking at this particular time in this country, where everybody is just juggling for the next, who's going to be the next president? Or, we don't know who's the next president, actually, whether we still have the same one. So we need to minimize such uncertainty in order to be able to strengthen resilience to pandemics. Provide open and accessible information through participation of citizens and citizen engagement. And again, the most effective way to do that is to localize global health security. We need to work with, the HIV movement and civil society organization showed how this can be effective when you do it at the community level. Of course, we need to combat corruption and use resources and take decisions in public interest. Not just to say it, it should show it as well. And finally, need to improve living conditions for all, irrespective of gender or socioeconomic status. In conclusion, as I summarize, there's need to effective community engagement, transparency and clear communication will be necessary, and it's captured in the 3 C's: complacency, knowledge of risk to persons. We must not assume everybody knows it. We need to build confidence in the system, particularly leadership and governance, an important building block of the health system. And of course, as I said, the OECD talks about your political system as well, and the social safety net. We need to communicate collective responsibility. I remember sitting in one of those committees, and I'm not going to mention, we were just wondering what was happening to communication. We were busy looking at data every week and trying to predict, with Bruce Melado giving us hotspots, 2 weeks before the wave or the surge was to happen. We knew all of that, but we were not seeing communication effective. And down the line, I heard 150 million rand of communication money was gone into corruption. It was just a crazy time. So important thing about resilience is not just to recover, but you have to learn from. If you don't learn lessons, you do not build resilience. So yes, all of this happened, but we need to learn from them. So collective responsibility, community and the state, and private and public. National solidarity was also very important. And some of the gains we made was because of those, actually, I must say. The WHO used to have these determinants of vaccine acceptance, and they've now added the issue of collective responsibility, because they also realized during the COVID that this was very important, private and public, and the state as well. And of course, issues of constraint, to be open and transparent about what the constraints are, so that everybody don't blame each other. We need to co-create with the local population, particularly those of lower socioeconomic status, on what is the best solution. It's great to promote MPI, but there are innovations that might be needed to allow for a greater response from this vulnerable population. A need for research on local community needs, I cannot overemphasize. And importantly, ethically driven social justice policies are not just compatible, but also instrumentally important element in addressing pandemics in an effective way. And finally, the evaluation of outcomes should not only be looking at deaths, but we should also be looking at how the extent in which some of this intervention impacts on health service or healthcare in broader sense, social justice and equity, because we now know outbreaks are not just public health emergencies, but also political and socioeconomic emergencies. And hopefully from the presentation, we can avoid in future this biomedical tunnel that the scientists took, and of course the need for the state to be more responsive and respond in public interest rather than their own personal interest. Thank you very much.
Do you have any questions?
My question is about ethnically driven social policies. Prof, in the context of South Africa, do you foresee anything wrong or maybe conflict or whatever if we go this type of route, looking at ethnically driven social policies? We know exactly the device that we have in South Africa, and if we should adopt such types of policies, is this going to be, is there anything that you see that maybe it will bring other unintended consequences?
The important thing to note is having ethically driven social policy is quite instrumental to preparing for pandemics. And it will require a collective nationally of civil society that takes the value system of fairness, for example, and distributive justice in policy, whether it's resource allocation. And it is actually in South Africa, I mean, this is known as a country with the strongest human rights focus written in its constitution. It's a value-laden constitution. So I don't see a problem doing it. The problem is actually implementing, and that's the challenge. And it will require everybody, including civil society. We cannot rely on government to just implement ethically driven policy. They can write it, but I think we need civil society to actually drive it.